Welcome to Get Briefed Podcast, the latest MDBriefCase group offering developed to inform healthcare practitioners regarding a variety of relevant medical topics. This podcast is available at www.mdbriefcase.com. The views, information, and opinions expressed in this podcast are solely those of the individuals involved and do not represent those of MDBriefCase. This podcast does not constitute medical advice and is only meant to educate and inform the listener. Please enjoy.
I'm Dawn Rae Downton. Today we have our expert physician tag team back to continue our deep dive into chronic pain. Is this the podcast you've been waiting for? Maybe it is, since today we're talking about whether or not opiates can and should be used for treating chronic pain. Are they effective? Are they dangerous? You've seen the news. You've had advice about prescribing opiates from your regulatory college. And so the answers to those two questions are no and yes, right? No, opiates are not effective. And yes, they're really, really dangerous. They're highly addictive. And they don't work anyway. Patients only think they work. The truth is that patients with pain who found opiates helpful don't want to come off them only because they don't want to go into withdrawal. Or is that the truth? Can we believe what we hear? Today we have Dr. Kaplan and Dr. Hauptman to unpack the headlines and the mythology they've helped create. Hauptman is a pain consultant practicing in Edmonton and an assistant clinical professor with the Department of Family Medicine at the University of Alberta. He's also one of the founding members of the Pain Society of Alberta and the Alberta Medical Association's Chronic Pain Section. Kaplan is a family physician in Ontario's York region. He's also a pain consultant and a clinical lecturer at the University of Toronto. Dr. Hauptman, Dr. Kaplan, thanks for joining us once again.
Super. Great to be back, Dawn.
Hey, Dawn.
Thanks. Dr. Kaplan, this is possibly the first time in history where a therapy that appears to work well without significant downsides on a significant problem is nonetheless hustled out of the formulary. So let me ask you, when, if ever, should clinicians consider treating chronic pain with opiates?
The question of whether clinicians should use opioids for chronic pain has to go back to a couple of steps. The first question, of course, is do opioids work for chronic pain? And we have to understand, of course, that chronic pain and acute pain are different. Acute pain is an acute, noxious injury that causes damage to the tissue and does require the appropriate treatment for the problem. Often, if we undertreat acute pain, we do get chronic pain. But chronic pain is a different condition than acute pain. It's a change of the nervous system with something called neuroplasticity. And a wonderful resource for this is a YouTube video called Understanding Pain. You can look this up, which talks about how pain is something that in a chronic situation is felt in the brain itself, and it's a change in the nervous system. We talked about this in previous podcasts. But this is very important because medications work on nerve pain differently than nociceptive pain or tissue damage pain. So the classic model of using opioids for acute pain does not necessarily translate to chronic pain. That being said, when a patient has had chronic pain and has tried many other alternatives for management and has still been unsuccessful, or on top of those other treatments, sometimes we have to add in some opioids to give patients the relief they need from this horrific problem of having chronic pain. The other side of this, and the reason why there's such controversy over it, is because there are safety concerns as well. And most of the safety concerns that are now occurring related to overdoses and so on have nothing to do with what clinicians prescribe. It's got to do with illicit drugs being brought in from across the ocean and illicit fentanyl lacing heroin and people dying of multiple drug overdoses combined with benzodiazepines and alcohol, etc. Has nothing to do with clinician prescriptions, but just the same, that there is a very small number of patients that may have this problem turned on by the prescription of proper pharmacologic drugs that we've given in our practices. So, Dawn, to answer the question is a little long-winded, but the basic answer is if it's the right person, the right medication at the right time, we have success. And as clinicians, we have to ensure that we're giving the right person the right treatment. And opioids are absolutely one of the choices we have for the management of chronic pain.
Sorry, go ahead. So, Dr. Hauptman, I was going to ask you if you wanted to add anything to that.
No, thank you, Dawn. I want to emphasize Dr. Kaplan's point. Clearly, opioids work very well when tissue damage is involved. This, again, would be more consistent with things like acute pain and cancer pain. When it comes to chronic pain, the pharmacological toolbox that we can utilize as physicians do work, but not in all patients. So whereas opioids may work virtually in all patients for acute pain, they might work for, depending on which study you read, anywhere from 30 to 40% of people with chronic pain. This is very similar to the other medications we have in our toolbox, such as anticonvulsants and antidepressants. We wouldn't throw those meds out just because they work only for 30 to 40% of our pain population. Likewise, we shouldn't throw opioids out just because they work for 30 to 40% of the population. Even our Canadian guidelines that are currently being utilized across Canada, when they looked at the use of opioids in chronic pain and compared them to NSAIDs, Nabilone, tricyclic antidepressants, and, interestingly enough, Mexilatine, there was virtually no difference between opioids and all those other drugs in terms of pain reduction. What that means is opioids work in some patients, NSAIDs work in some patients, Nabilones work in some patients, TCAs work in some patients, but not in everyone with chronic pain.
Okay, so we know that they work in a considerable percentage of the chronic pain population. And Dr. Kaplan, you've just pointed out that as far as their safety profile re-addiction goes, that the overdoses and overdose deaths that we're seeing, particularly in British Columbia, and I guess second to that in Alberta, really have very, very little to do with anything that you're prescribing or Dr. Hauptman is prescribing or any clinician in Canada is prescribing. We know that. What about other aspects of safety or danger in opiates? Are there serious downsides to opiates? And I guess in answering that question, we should also consider whether there are serious downsides in alternatives to opiates, like anti-inflammatories and the other drugs that you were mentioning, TCAs and so on. Dr. Kaplan, that's a question to you.
Yeah, absolutely, Dawn. I think the issues here that happen with opioids, and as Dr. Hauptman said, we don't throw it out just because it doesn't work in everybody. The other side of the equation is that there has been some harm from them. Part of that harm actually can be traced back to clinicians, and this is because we learn as we go. When I first started practicing pain medicine, we used to push our doses of opioids up fairly high, believing that because they don't cause any tissue damage directly, that they were reasonably safe. This has been shown over time to be maybe not quite as true because we are understanding that there are some side effects that occur from opioid use, especially as the doses get higher. And these side effects are the obvious ones, such as constipation and nausea, but the sedation and cognitive changes that can occur because of opioids, while not being recognized initially by the patients, probably are more significant than we had given it credit for. In addition, some of the other side effects like worsening of sleep apnea, some adrenal issues and endocrine issues can also occur. So we've now learned that there are some harm to very high doses of opioids, and that's a learning that's happened over the last 20 years. It's not something that we did wrong on purpose. And now, not incorrectly, we're talking about maybe bringing patients down to the lowest effective dose of the medication that is there for them. Not no dose of medication, but the lowest effective dose of medication. And I think you're quite astute to pick up the fact that everything we use has the potential for side effects. Tricyclic antidepressants, which are used very regularly, have all kinds of side effects, including urinary retention and glaucoma and sedation in themselves. Newer antidepressants, such as duloxetine, can cause blood pressure elevation and nausea. Anti-inflammatories are probably one of the most dangerous drugs that we use, causing upper GI bleeds and colitis and renal failure and heart failure and all kinds of really bad things. They're very dangerous drugs that we use also very readily without those same kind of concerns. My personal opinion is that the opioid deaths have made this a very political, the overdose deaths have made this a very political issue, and it's allowed people to have a big say into something that has really no relevance to the management of the medications that we're talking about.
Right. We've said in so many ways, even only just this morning, that there's a marked belief out there that medical use leads to addiction, and as you have both pointed out, that's not the case. I think a lot of this comes out of a discussion that we're seeing more and more where clinicians and other writers are turning out studies and commentary that says that physical dependence is the same as addiction. We're seeing that a lot. Physical dependence equals addiction, or it may as well, because they're both equally bad. We've discussed this briefly on another podcast, but could we come back to it at this point in looking at whether or not to use opiates? Is physical dependence addiction? Can it lead to addiction? Is it bad on its own?
Sure. Let me tackle this.
Sure.
One,
sure, Dr. Hauptman.
Because again, it's such an important question, and particularly for family physicians to understand. So dependency can happen with many drugs. It's a pharmacological property that you see not only with opioids, but you can see with SNRIs, you can see with certain blood pressure pills like beta blockers. Basically what dependency means, or physiological dependency means, is that when you stop the drug, suddenly you go into withdrawal. That's not addiction. Addiction, traditionally, we talk about the 4 C's, the loss of control, use despite consequences, cravings, and compulsive use. So in a person who is addicted, for example, to opioids, what this might represent is somebody who can't just take one oxycodone pill, they have to take 20, for example. They are often losing their prescriptions. They are asking for continual early refills. So these are some of the things that might suggest some of that loss of control, use despite consequences. They don't care about the side effects. They just want more and more. They start to see a decrease in their social functioning, their ability to function in their occupation. So these are all signs of addiction. And to be clear, opioids can cause addiction. This is a well-known fact. In the chronic pain population, this is not zero. And depending on which study you look at, and there's been a lot of studies looking at this, the best studies that I've seen in reviews put the risk of addiction in well-screened patients in the 1% to 5% range. This is lower than the general population, somewhat higher than the general population, but it's still there, and we have to be aware of that risk. But it is not 80% of patients. It is not 50% of patients. It is not even 10% of patients. It's somewhere in that 1% to 5% of patients.
Right. And can Dr. Kaplan, maybe you can weigh in here on the term tolerance, because it's often talked about when we talk about dependence. It has something to do with dependence, of course. Could you just maybe clarify tolerance for listeners?
Tolerance is the concept that as you use something for a long time, your body gets used to it. I think we're all familiar with benzodiazepines in this situation as well, in that if you use benzodiazepines chronically, your body creates new GABA receptors that need to be filled, therefore you require a higher dose to get the same benefit. So tolerance means you need a higher dose to get the same benefit because your body has gotten used to the drug that has been on board.
And again, is tolerance in itself a bad thing? We often hear that it is. And so what do you think about that, Dr. Kaplan?
I think it goes back to the question of, my patient wants a higher dose. Oh my God, what's going on? Are they asking for a higher dose because they're addicts? Are they asking for a higher dose because they become tolerant to the drug? Are they asking for a higher dose because they're selling it? And that's the concern that the doctor always has. And it's very hard to actually tell that in some people. But for the most part, it's not surprising that the use of a medication like an opioid, where the body can create new opioid receptors, may lead to some tolerance over time. This has nothing to do with addiction. But of course, one of the things you have to think about when someone is requiring a higher dose is, are they using it for the right reasons? And one of the correct reasons may be tolerance. A solution to this problem, by the way, is to rotate your opioids rather than increasing the same dose, switching drugs, which then your body will have to learn how to use the new drug, and therefore you don't develop quite the same tolerance.
Okay, thanks. Go ahead.
I was going to say, Dawn, before you move on to this point, because tolerance is often talked about, but if you look at large series among chronic pain patients in pain clinics, it is really interesting to see what is the actual incidence of tolerance. I've seen published reports now upwards of 10 years of patients, chronic pain patients, being on the exact same dose of opioids and apparently getting the same benefit. So these are often case series done by clinicians who work in the area of pain. But even in my own personal experience in my pain practice, it is really not a frequent occurrence where I have to keep increasing the dose to get the same amount of efficacy.
Okay. Dr. Kaplan had mentioned that there could be a number of reasons why a patient is telling his or her clinician that he needs a higher dose, and some of them are less insidious than others. Some of them have nothing to do with drug seeking. What about, one of the things that Dr. Kaplan you didn't mention is the possibility that the underlying condition that's causing the pain over time is degenerating, is progressing, is getting worse. Can that lead to tolerance? What I'm asking is that a reason why the patient would want more pain relief, because the patient has more pain?
Sure, there's certainly a number of other reasons I didn't touch on in terms of why people make the dose increase. I just touched on a few of them, but certainly the condition itself getting worse, especially in a progressive inflammatory condition, may be one. A different diagnosis entirely that's complicating the first one, maybe two. Right. A comorbidity or a different treatment that affects the metabolism of the drug in the first place, maybe three. There's a number of other things that can cause this to occur, and I think that's part of the reevaluation has to happen when someone comes in requesting a higher dose, understanding the reasons why and thinking beyond just the obvious in front of you.
Indeed.
And to Dr. Kaplan's point, probably the most common reason that I see why patients will request a higher dose is either increased stress in their lives or a new mental health diagnosis. So we have to recognize that in chronic pain in particular, stress and emotional issues can make the pain worse temporarily. And it makes intuitive sense. Most of us who don't have pain can, recognize that maybe after a hard day at work, maybe a bit of stress in our own lives, we might develop a headache, for example. There's an example of pain resulting from an emotional situation. Again, it doesn't mean they don't have underlying real pain, but rather there is one of the, there's another source that's leading to that increase. So we often have to parry down, why is this pain currently worse? And I think Dr. Kaplan has given some examples. Like I said, what I see in my practice is often, stress or mental health problems, and once these resolve, the pain returns to baseline. I think sometimes clinicians feel when people come in, the easiest solution is to just, give more meds. But I think sometimes if we step back, and I think this was what Dr. Kaplan was alluding to, and try to understand why the patient's making that request, then, we can get to a better way of treating the actual increase in pain.
Indeed. It strikes me that it's a really complicated process to evaluate pain in in any patient and then figure out how best to treat it and follow up. So I think it's good that you guys are laying out a way to approach this. I want to talk about what considerations go into customizing a treatment plan, patient to patient to patient. And I want to begin by talking about dose. We've been hearing a lot about the best dose for patients to be at for opioids, or at least the best dose not to exceed. So, Dr. Kaplan, is there a single best dose for opiates? And is there a ceiling? Should there be a ceiling? Is that appropriate?
Well, I think the simple way to answer that question is the best dose is the dose that's efficacious with least downsides and the most safety, and the one that allows the most function. In a perfect world, we'd have a medication that caused zero pain, but of course, a situation of chronic pain, it's unlikely to occur to reach zero pain without modifying the actual cause of the pain and changing the neurologic system. Mm-hmm. That's very unusual. So I think we're looking at the dose that's actually significant pain relief with improvement function without causing any downside. As far as the ceiling, there's been a number of arbitrary ceilings created over the last number of years. The first was a morphine equivalent of 200 milligrams with our guidelines years ago. Initially, that number was 300, then it got pushed down to 200, and there was actually some rationale for that, because apparently, in terms of population risk of overdose, there seemed to be a relationship between the dose and the risk of overdose that increased over the dose of 200 milligrams. More recently, the guidelines switched down to 90 and 50 milligrams based on first the American model, then BC, and then the national Canadian guidelines, with, I think, much less evidence behind those particular numbers. I think they're a little bit more arbitrary.
Dr. Hauptman, you got any thoughts on that?
Yeah, I totally agree with Dr. Kaplan. I do think that primary care physicians, who we are really targeting this podcast to, need to be at least aware of that 90 milligrams. And it's not to say that should be a hard dosing limit for every single patient. But what it does do is give physicians a mark where they might want to say, okay, my patient's now going over 90 milligrams. Maybe I need to relook at the diagnosis. Maybe I need to at least think, could there be some diversion involved or some substance abuse issues here? And at the very least, consider referring to somebody who works in pain medicine. That I think is appropriate. Now, in my pain practice, I will sometimes go higher doses, although in the vast majority, and I've looked at this in my patients, they do seem to get benefit at a dose of morphine equivalents of under 200 milligrams. I do have a few people with severe, often very much intractable neuropathic pain syndromes that are higher, and very few people that are, in fact, even as high as 1,000 milligrams of morphine equivalents. Those are often people from the old days when we were pushing the doses a lot higher. But we have to try to individualize, really look at individualizing our treatments for these patients. I think the point to family doctors is that 90 to 100 milligram mark is one that they need to at least have in the back of their mind. And if they feel their patients need more, not necessarily discount the patients, but again, go back, look at the entire clinical picture, and if appropriate, refer the person to a pain consultant. Now, granted, that might take 12 months, 18 months, even 2 years, but I don't think the message we want here is that everybody over 100 milligrams of morphine equivalents are somehow bad patients, or they're all abusing their medication, or that it's 100% inappropriate. Because clearly in some people, they do need higher doses.
Dr. Hauptman, sorry, can I interrupt you, Dr. Kaplan, just because I want to follow up on a tiny detail of what Dr. Hauptman said, and it's to ask about so-called legacy patients. He had mentioned that occasionally he and other clinicians will end up with patients who go back a ways and are on doses perhaps as high as 1,000 morphine equivalents, because that was when doctors were prescribing more readily, more liberally. When you have a patient on, and Dr. Hauptman, this is to you, and Dr. Kaplan, please join in if you have thoughts. When you have a patient on a very high dose like that, like 1,000 morphine equivalents, and that patient is stable, doing really, really well, seems to have no downsides, seems to have few side effects, that he's managing just fine if he has them. What do you do with that patient? Do you just reduce them because that's what's out there? That's the orthodoxy?
Well, I think you have to look very seriously at that population, because I've taken a look at my own practice and taken a look at the literature, and what I tend to do with that population is I do reduce their dose very slowly, maybe 5% every month to 3 months, to see if we can get to, again, the lowest effective dose. And here's the key here. It's very clear in the guidelines, particularly the Canadian guidelines, that we want patients not on the lowest dose, but the lowest effective dose. And in some patients, when I've taken this approach, particularly the legacy patients, I have been able to reduce the dose 5%, 10%, 20%, in some patients even upwards of 50%, and they seem to have done very well. Slowly, though. I think this is a big mistake that's out there with the guidelines, this idea that wow, we've got to get these people off fast. No. That's silly. It's not really inappropriate when you think about it. In medicine, in every other condition we treat, when we put people on medications, it is always to the lowest effective dose. So if somebody has hypertension and we put them on Norvasc, although we could put them on 20 milligrams of Norvasc, that's a very potent antihypertensive, they may only need 2.5 milligrams. And likewise, I think this is where we have to look back at that population that are our legacy patients. Maybe instead of 1,000 milligrams of morphine equivalents, they could do just fine on 900 milligrams of morphine equivalents. So the question is, why would we do that? Well, any reduction in medication has that potential to reduce any potential side effects, even side effects that the patient may not readily appreciate. Now, the final word on this, and then I'll let Dr. Kaplan add if he would like, is if we do reduce doses, and it is quite clear that the patient is not doing well, in other words, their function is deteriorating or their pain is significantly worsening, then we stop the reduction. That is clear because then we found that they are previously on what for them was the lowest effective dose.
Okay, and you wouldn't assume, as some clinicians and writers on the subject do in Canada, that if a patient on a taper experiences pain, that's not withdrawal pain. I mean, we hear that a lot, that's just withdrawal pain and they'll get over it. You don't think that's the case?
Sure, I'll take this. I do believe there is a component of withdrawal pain, but that withdrawal pain, as I've experienced in my population and as I've heard other clinicians speak about this, should only last for about a week, maybe 2 weeks at best. So I warn people about this. I say that might be a sudden increase in your pain. But clearly if I reduce the dose and the pain levels go up and they are not coming back down to baseline after 1 to 2 weeks, then I don't believe at that point we're dealing with withdrawal pain any longer.
Okay. Dr. Kaplan, I'm sure you want to get in here.
A couple of things. First of all, we're going to have an entire podcast on opioid withdrawal that's coming up next.
Right.
So this is going to be a little bit more detail. So I won't get into that a whole lot more. I want to go back to your initial question about ceiling. And I'd like to change the terminology a little bit from ceiling to what we used to say, which is called watchful dose. And what this means is when you hit that dose, and Dr. Hubb has talked about 100 milligrams or 90 milligrams, you have to think about why you're there and what has brought you there, and should you either increase or decrease depending on the clinical circumstance. It is not an absolute ceiling. It's a dose that says we have to pay attention to how we got here, recognizing the doses above this may be more problematic. So going through all the steps we've already talked about, when someone is at that dose and is requesting more, you go through those steps and understand why patients are, but it's not an absolute ceiling. It just means that if you're going to increase it, you have to have a pretty good reason why, and you have to have a thought process in mind, not just reflexively increasing the dose because patients are asking for more. That's how we got into the situation of such high doses where we are today. So with that background, we then say, okay, we have this watchful dose. We're going to understand why the patient requires more. Should we increase or should we consider decreasing? And, of course, a lot of this is driven by both guidelines and now, of course, by organizations that are pushing this opioid withdrawal with their own particular agendas. And as I said before, I think a lot of these are political. They're not based on reality. The medications we're prescribing are not what's killing people. And we have to understand that we have to do well with the patient in front of us at that particular moment. Dr. Hauptman said make a referral to a pain clinic. Well, I know what the waits are, at least in Ontario, and they're tremendously long and frustrating for the primary care doc. So what it says in our guidelines is feel free to refer to a peer. And a peer can be another family doctor, where at least in your clinic or in your group, you have someone else who you can talk to and say, I just want to run this guy by you, this patient by you, and say, does this seem reasonable to you, or do you think I might be missing something? And at least that way we've had a couple of heads thinking about someone who's a very complicated situation. My last sort of analogy for this is it's not really surprising for us to have to increase medication for pain in conditions that are chronic and unremitting. And if we think about a condition like type 2 diabetes, this is a condition of progressive failure of the endocrine part of the pancreas. And your patients with type 2 diabetes, you're often adding on medications. You go with metformin, adding on then an SGLT2 or GLP-1 or sulfonylurea or insulin because the condition continues over time to deteriorate. But that's okay in diabetes, but Lord help you if you do it in pain and add in more medications for pain. But understanding the other side of this, you understand what the side effects of are your your SGLT2 drug in terms of dehydration and things like that, you have to understand what the side effects of increasing analgesics may be as well.
Yes. Okay. Let's talk about opiates a little more technically. What are the strong opiates and what are the weak ones, and what's the difference?
Well, sure.
Sorry, Dr. Hauptman. Let's go to you.
Okay. So I think a better way to look at opioids, to be honest with you, is what I would call traditional opioids and either non-traditional or atypical opioids. So the traditional opioids are opioids that work primarily on the mu opioid receptor. And these would include drugs like oxycodone, hydromorphone, morphine, codeine, fentanyl. These tend to be very specific in most of the cases for the mu opioid receptor and do not have a lot of effects on other receptors in the body. The non-traditional, or what I would call maybe the atypical opioids, are opioids that not only work on the mu opioid receptor, but also work on other mechanisms. This would include things like tramadol, which works on opioid receptors, but also has SNRI activity, tapentadol, which works on the opioid receptor, but also has NRI activity, buprenorphine, which is not a full opioid agonist, but a partial opioid agonist, and even methadone that not only works on the mu opioid receptor, but works a bit on serotonin and also has some NMDA blocking properties. This distinction between traditional opioids and non-traditional opioids is very important clinically because when it comes to chronic pain, in many cases, patients tend to respond better to the non-traditionals than they do the traditionals. And in some cases, the traditional opioids, in fact, don't work. This would include things like fibromyalgia and chronic daily headache syndromes. For the majority of patients with those conditions, traditional opioids not only don't work, but they can make the patient worse. However, there is some case to be made for the non-traditional opioids in some of those conditions. So, for example, there's data for the use of tramadol in people with fibromyalgia. Now, to point in terms of weak versus strong opioids, I think that distinction can get a bit confusing because for any milligram doses, you can actually find an equivalent analgesic dose. So, for example, 10 milligrams of morphine is equivalent to 2 milligrams of Dilaudid, hydromorphone. So you could say that hydromorphone is 5 times stronger, but 10 milligrams of morphine theoretically will give you as much analgesia as 2 milligrams of hydromorphone.
Right.
So I think that distinction we have to be careful with. I like the broader distinction between traditional versus non-traditional opioids.
Thank you. Dr. Kaplan, anything to add there? Should I ask you something completely different?
The only thing I was going to add to that perfect answer, which is almost word for word what I would have said, is that the other, when people talk about strong versus weak, the other factor here is the risk of misuse of the medications. And the pure mu opioid receptors are the ones that are probably misused a little bit more than the non-traditional ones. That being said, any medication can be misused by someone who has an addiction disorder, and methadone is a drug that has also been misused, even though it's also part of the treatment plan for people with opioid use disorders. So part of the issue here is the risk of misuse of medication because of its efficacy.
Yeah, and I couldn't agree more with Dr. Kaplan on this point. And I think just to emphasize, really what gets abused by the population, it is what really is the most available when it comes to people with opioid use disorder. So in the day when OxyContin was being prescribed a lot more in North America, some of that got into the street supply, and that's what people were abusing. For a time in Vancouver, tramadol was the most abused opioid because that's what was available. When Oxy-Neo was introduced to the Canadian and North American market, people didn't like it as much. It was more difficult to abuse, so they went to initially heroin and then subsequently, unfortunately, fentanyl, illicit fentanyl, which we now see. So what drives substance abuse, what people are abusing, is really not the drugs themselves per se, but availability. And why this is so vitally important is some physicians do get into the habit of saying, I'm just going to use codeine because no one's going to abuse codeine because it's a weak opioid, let's say. Well, that's not true. If we use enough codeine and that's all that's available, codeine will be abused on the street. Likewise, if all we ever use is tramadol, then tramadol sometimes will get into the street, and that's what people will use. So that's why no matter what opioid we use, or in fact whatever drug we use for chronic pain, we have to prescribe safely. As you know, Dawn, and I know Dr. Kaplan knows this, we're actually now seeing things of abuse that we wouldn't have considered. Gabapentins being abused, which we use for chronic pain. Pregabalins being abused, which we also use for chronic pain. So we just have to be mindful not to demonize one group of drugs and say, I'm never going to prescribe that group of drugs. Rather, we should look at each patient individually, make a treatment plan for them, and try to prescribe safely so we minimize risk to the patient and minimize risk to the community.
I'm glad that we talked about abuse just then, because I wanted to talk in terms of prescribing opiates about how physicians should screen for addiction risk. We touched on this in our last podcast, but I think it's important to come back to it here. You had mentioned previously in our last podcast that there are various tools out there for physicians. One of them, I'm blanking on what it's actually called, but it's an opioid, an addiction risk assessment tool. I don't think it's called that, but that's basically what it is. So, Dr. Kaplan, could you tell us what the actual title of that tool is, and could you talk to us a little bit about how to screen patients to make sure that you're not looking at someone thinking of prescribing him opiates where he might be an addiction risk? How do you determine it?
Sure. One of the things that gets the clinicians into trouble is starting a medication without having done that kind of proper assessment first. And unfortunately, this can happen in the acute pain world, and we're not trained and we don't think about, as we give somebody a prescription for an opioid for their acute pain, do they have an addiction risk even at that stage? By the time it turns into chronic pain, they've been on the medication for a little while, and sometimes that's even late in the process, and it complicates it. But the risk tool is called, very simply, the opioid risk tool. And this is a component that asks questions about their personal use of substances in the past, either illicit or prescription, their family history of that, their age, because younger people have a little higher risk than older, their psychological issues, because one of the things that can happen is patients will use an opioid to treat their psychological pain, PTSD, depression, things like that, because the use of an opioid does make you feel better for a short period of time, and people can depend on that for that reason. I had one patient who was up to 20 Percocet a day who was using them for anxiety. And once I asked that very simple question of why we're using so many, that came across treating with an SSRI and some counseling at his medication use for his chronic headache. And the last thing is a history of sexual abuse, and that's another form, I suppose, of PTSD. And sometimes patients are hiding or not dealing with that past abuse and not recognizing it and hiding it with the use of opioids. So the issue here is there some condition that the patient has that might make them use the medication for a reason other than what it was prescribed for? So those are the opioid risk tools available online, and we'll have it as an attachment to the program. But the other things that are not asked about are still important here. So other medical issues are important, but other addictive behaviors. And of course, the number one addictive behavior that we have in North America is smoking. Alcohol is included in the illicit substances that I've already mentioned, but remember smoking. And there's other behaviors that people have, like gambling and things like that people don't have good stops to their behavior, and therefore may go on to do things that we think is not appropriate. So what you're doing is you're looking at the patient saying, is there any reason why this person might use the medication that we're prescribing? And this can be opioids, but it can also include the Lyrica, the gabapentins, the benzodiazepines, the sedating medications, the muscle relaxants, any reason they could use these medications for reasons other than what they're prescribed.
There are also, Dr. Hauptman, other tools that physicians are using to make sure that they're treating the right patients with the right drugs. I will just briefly mention a couple of them, and I just want to mention a couple of things about them from the patient's point of view, and ask you, Dr. Hauptman, and you too, Dr. Kaplan, if you want to jump in, how physicians see these tools. I'm speaking specifically about treatment agreements, which are relatively new to Canada, where patients are made to sign off on various guarantees, provisions. One of them is, that you'll always always use the same drugstore. You won't double doctor is another. A third is that if you need an earlier refill for any reason, you will be denied it. I always wonder about that one. My God, what if someone's house burns down and their prescription in it? Well, any reason, including if your house burns down. So patients find this one a bit troublesome, and I think that that urine drug screening is often very offensive to many patients, particularly legacy patients who've been on their opiates for a long time and use them very responsibly with very good results and minimal or no problems. There has been a lot of written on treatment agreements and urine drug screening from the patient's point of view. Many experts feel that these sorts of things destroy the doctor-patient relationship, which has usually been built up over years, and its relationship of trust, which is now kind of shattered on the floor. That's how many, I would suggest, patients see it. From the doctor's point of view, are these things useful and are they essential, and how can the doctor preserve the relationship in the face of them?
Well, I think, Dawn, these are great questions. And, early on when these were being propagated as ways to reduce risk, I had, the same concerns. I think we were isolating a group of patients and saying to them, you have to do all these things or I, quote unquote, may not prescribe for you. And it made me think, do we have a anti-inflammatory contract? Do we have a COPD contract or agreement? They used to be called contracts. Now we call them agreements. So I understand the pejorative nature. What I now believe, though, is this is a source of education. I think this is how we, as physicians, should be presenting this to our patients. This treatment agreement just outlines some of the things that I'm responsible for as your physician and some of the things that you're responsible for as a patient. And I think they're not really that bad. And when you put it to the patient, they can understand, like safe storage. I mean, nobody would think of safe storage, for example, of a blood pressure pill. But you got to think safe storage of an opioid. We know that when prescription opioids were ending up on the street, about 70 to 80% of them were coming from valid patients. Not that these valid patients were selling them, but the typical story was somebody in the house would go into the bathroom and siphon off a few of the pills. So no one would do that with the blood pressure pill, of course, as I mentioned. So I think making patients aware that these meds do have value, for example, on the street, is a good thing. I think that going to one pharmacy is a good thing. It allows for a relationship to be built with that pharmacist, particularly if the patient then needs, for example, something like an antibiotic. They're going to go to a pharmacist who understands what they're on.
Right.
So I think those are good things as well. I don't believe, though, these agreements should be seen in the sense of a contractual relationship. That destroys the patient-doctor relationship, such that if you, quote-unquote, break the agreement, you're subsequently fired out of the practice. Anytime there's a behavior that is seen as being what we would call aberrant, that's an opportunity to review what's actually going on with the patient. And as you pointed out, sometimes it's very valid. A patient wants to go for a 3-month vacation. They may need an early refill. Somebody's house burns down. Again, they may need an early refill.
They need more than an early refill, right?
Yeah, exactly. But here's an interesting thing. The literature's looked at this, and they've looked at what we often would call the 3-strike rule. And if you have 3 or less strikes, aberrant behaviors, your chance of being diagnosed with an opioid use disorder is about 1%. However, if you are higher than 3 strikes, the chance of being diagnosed with an opioid use disorder is about 10%. It goes up tenfold. So if a person continually asks an early release, over and over again, if a person's always using their medications, this should be a warning sign for the clinician to reevaluate the patient. Now, as far as urine drug testing goes, I'm finding less and less patients are offended by them than in the past, because they just open the paper every week and they understand the whole issues around opioids more. So I find my patients are more than happy for 2 reasons. They understand that there's a problem with illicit fentanyls in the community, and secondly, they understand that I'm willing to treat them. And so few people are out there willing to treat. They'll come in and do any lab tests with me that I want them to do. So I know some of this is just protecting me from my regulatory body, There's almost no literature suggesting that urine drug screening and treatment agreements actually makes a difference in hard outcomes. So you can't find literature necessarily supporting them. They're in guidelines and they're recommended. But if you look at studies saying, do these really make a difference, they're not out there. Nevertheless, it is vitally important for primary care physicians who manage people with pain that they are doing these tools, that they are utilizing these tools to help as much as anything to protect them.
But I do have to point out, and you just said it yourself, that patients are over a barrel because they have to do whatever they have to do in order to continue to get treatment. So they may not want to sign that treatment agreement, and they might not want to submit to urine drug screening, but they have to if they want the treatment. So it's an unbalanced relationship from the patient's point of view. The patient feels manipulated. Some of them, anyway, many of them, I think. Dr. Kaplan, I think we should move on maybe to something else. What I wanted to know is when you have a patient on opiates, is there an accepted protocol for following up? How do you do that? Is there a schedule? What do you do, Dr. Kaplan?
Well, yeah, there's a number of things you should follow up for your patient who's on opioids. And this doesn't necessarily have to take a long time. I can reassure the clinicians listening to the podcast that once you've gone through the processes and talked about the appropriate screening, the appropriate medication, the appropriate efficacy of the drug, and ruling out side effects, you can just have a very quick conversation with most of the patients with pain when they're doing well. It's only when they're not doing well that you have to then spend more time to understand what's going on. And I would purport that most patients actually do fine very early on in the process, and once they found a happy medium, do not require a lot of your time. The follow-up that's required is some pretty basic things. We talked about the 6 A's yesterday, and we talked about the concern about things like urine drug screening just now. So let me lay those out. The idea here is the patient having enough analgesia, A, number one? Is there any concern about aberrant behavior, the accurate log of the medications? As a clinician, write down what prescription you're giving. Sometimes we find that doctors' records are not really quite good enough to understand what actual prescriptions they've given, which is a little bit concerning. How's the patient's affect? Have there been any adverse effects of the medications? So those are the A's that we talked about, and then, of course, affect we talked about before. Urine drug screening comes into this as part of it. Does it have to happen every visit, every time? Well, no, of course not. You're going to titrate the frequency of how often you're going to do a urine based on your concern and your opioid risk level. So if you have someone whose opioid risk tool score is high, we talked about that we do this, but that doesn't mean that someone has a high level of risk, because it's a risk tool, should not be prescribed the medication for pain. It just means you have to pay a little closer attention to them, because sometimes, and whether the patient likes it or not, Dawn, and I can understand how you might find this offensive, sometimes we have to actually protect the patient from themselves. And we know that we don't want the wrong person to start using the medication in the wrong way. And we have to do that as a job. We also have to assess whether or not the drug has been efficacious. As this medication, which has its downsides, is it working? So I wouldn't give somebody a diabetes drug that's causing them side effects, even if the A1C was normal. I would change it to something different, and we have to do that all the time. You know, if your blood pressure is perfect on, Rob talked about Norvasc, if your blood pressure is perfect on Norvasc, but your legs are swollen, you're not going to say, well, too bad, live with your swollen legs, we're going to leave you on the Norvasc. Blood pressure is normal. No, we're going to switch your blood pressure medication. So we're looking at efficacy, we're looking at adverse effects, we're looking at risk in terms of urines. And just to comment on the urines, sometimes, as a clinician, we have someone who we have absolutely no thought of anything being done incorrectly. And I think both Dr. Hauptman and I have had surprises on patients who've done urines and found things that we did not expect because all of our risk assessments were negative. So I think it is important to do this. And from the point of view of the patient, I understand how it will be somewhat offensive, but this is an opportunity, again, to have a conversation about why we're doing it. And I found that really, and I'll say not all, but the majority of patients understand the need of doing it. The majority of patients understand the need for why I do an agreement because of what's going on in the news. And the ones who have real concerns about giving a urine sample, the ones who won't do it, are virtually always people who have issues. Not always, but virtually always. So that's my message to the listeners. These are tools that I think now are certainly necessary from the college's point of view, but also in terms of common sense to protect both yourself and your patient, to do these things to make sure that everything is laid out for both you and the patient and how you're going to progress in the future.
Okay, let's go to a bottom line question. When you get to the end of the day with your patient on opiates and they fail, yet that patient has tried every other known therapy, or when a pain contract is broken to the extent that you feel that the relationship is broken, what does the doctor do in that case, and what does the patient do? The patient is out of options to manage his pain.
I think you just had two questions there, Dawn, so I'll quickly kind of put to them. The first question is, what about the person who fails opioid therapy and has failed all other therapies? Well, that does happen. As a pain consultant, I see people where nothing I have done makes that patient better, but I don't stop seeing them. I tend to believe that we have to continue to offer compassion and care for all our patients, irrespective of whether or not they respond to therapy. There are a number of chronic conditions that we treat where we, in fact, don't have really good therapies sometimes. For example, multiple sclerosis. Although we have therapies available, sometimes you still get somebody with rapidly progressive multiple sclerosis where there's virtually nothing you can do but try to hold their hand and walk with them through their journey. And I teach very much to doctors that that's what you're there for. As a primary care physician, you need to be there with the journey with your patient, whether or not they respond to therapies. And it does exist. Surprisingly less than people imagine. I would say in my pain practice, about 5% of patients are people with intractable pain where nothing I have given them or sent them for or treated them with has actually worked. So that's the first question. The second question is one about what about the person who's breaking the treatment agreement on a continual basis? Well, then it goes back to the reason why. And if the reason why is because they have a substance abuse disorder and they don't want to be treated for it, ultimately, if I try and try again and I just can't get them to a point of recognition and insight that we need to deal with this problem, I'm not the physician for them. But there's only one situation where I personally will ask the patient to leave my practice, and that is if I have conclusive proof that they're diverting medication. That is not a medical condition. That is a criminal behavior, and there is no doctor-patient therapeutic relationship in that case, in my opinion. All other conditions, I'll treat and I'll see the patient. Even my patients abusing a medication, I'll still see them because I have to, as a clinician, treat people with opiate abuse disorder. Opiate abuse disorder should not be seen as, again, a pejorative thing. So I think the two questions are there. What about the patient who doesn't respond to anything versus the patient who continually breaks the treatment agreement? Those are two separate issues, and I think we need to manage them differently.
Dr. Kaplan, just before I come to you on this, I just wanted to explain what I'm trying to get at is the end game for the patient and the doctor, however the end game comes along. Fair enough to say that when a pain contract is broken repeatedly, you're probably looking at an abuse issue, but I have seen pain contracts used in Canada that are one-strike pain contracts. You're allowed one strike, and then you're told that you may be discharged. I know that there are patients who have been discharged on actually no strikes. So just for whatever reason, you're looking at the end of using opiates in a patient where there is not an indication of abuse. My question is, and Dr. Kaplan, you take a shot at this if you would, what's out there for the patient? Is the patient just going to have to live with lifelong severe pain, if that's even possible to do? And what is the responsibility of the physician? I think Dr. Hauptman has outlined that well. What's your take on it, Dr. Kaplan?
Well, again, I think it's important to separate out the two different groups because they're very, very different. Remember that in any treatment process, it's a trial of treatment. And opioids are no different. Opioids are a trial of treatment. If that treatment is working effectively and safely, there's no reason to not continue it. We may be reducing doses. We'll talk about that in the next podcast. But the point is, why would you change anything other than external processes telling you to do so lately? We'll talk about that. The other bigger issue is if it's not working. Now, if it's not working, then the question, as Dr. Hauptman said, is why? If it's not working because it's not efficacious at all, the patients themselves will often recognize it's not working, and then you taper it off in a nice, slow process, and then get withdrawal from the process because they're not getting benefit from it; they're just getting the side effect of potential withdrawal and dependence. So we're getting rid of that. In patients where the problem is diversion, I completely agree with Dr. Hauptman. You do not have a clinician relationship there; you have a supplier relationship, and I will stop prescribing for that patient immediately because I'm not prescribing for them. They're selling it.
Sure.
The last group is the most difficult group. The group of patients who have opioid use disorder or have continuous behaviors that make us concerned about such. And sometimes it's not even the fact that they have use disorder. Sometimes it's the lack of an inherent understanding of the concerns about the medication, both clinically and, quite frankly, legally right now, and breaking the rules and chronically overusing medications and not understanding the limitations that are required. I think those limitations have to be fair and reasonable from the clinician point of view, but that conversation can occur. So I understand where you're coming from, Dawn. You're saying, well, that just sort of leaves the patient out, in the air with no treatment. But we're talking about a very small minority of people here. Unfortunately, the numbers have gotten bigger because of the way doctors are interpreting the new guidelines,
right,
that people must go all the way to off. And I think Dr. Hauptman and I have said very clearly that that's not the case. And speaking to the guideline authors, that's not what they mean either.
Right.
They mean reduction to the lowest effective dose, not stopping medications and putting people back into horrible pain. But if the medication is not working, or if the medication is being misused, or if you cannot have a working, trusting relationship with that patient, those are all pretty good reasons to consider changing this treatment program. And again, I'll analogize to diabetes. If you have someone who you think should do well on one medication, but they can't tolerate it, or they're not doing well with it, we're going to switch it to something else. And just sometimes do we have diabetic patients whose A1Cs don't get a perfection? Even we add insulin to their type 2 diabetes? Yes, we do. And that means that we haven't done as well as we could have done, but that's a patient-doctor combination of issues. And I don't think it's fair to say, even as a patient, that the doctor is just leaving them out there in the wind to fly with intractable pain. As long as you're approaching the patient, as Dr. Hauptman just talked about, sending them to as many different modalities of things you can do, and working with them, you can make a difference. And my last word on this is a patient of mine who really gave me a great insight into this. And Dr. Hauptman's heard this story before. This is a young lady with horrible neuropathic pain after a failed surgery. The details are not important. Who was tried on a variety of different medications and a variety of different treatment modalities, where basically nothing worked. And I was, of course, quite sad about this for her, and she was continuing to suffer. And one day I just said this to her, that I was sorry for her, that I really couldn't do anything. And she came back to me and said, "What are you talking about? You're the only person who's ever done anything for me." And I said, "But we haven't relieved your pain." She said, "Yeah, but you're the only person who's actually ever listened." And I think that makes the point that Dr. Hauptman said, that really our job is to remember to hear sometimes, diagnose often, but comfort always. And even the active physician relationship can still have value in someone who may have not had success with other modalities.
Yes, absolutely. Okay, Dr. Hauptman, Dr. Kaplan, thank you very much. I think this is an important discussion. It's, the question of whether to treat moderate to severe chronic pain with opiates is a question that's been burdening healthcare in Canada and the U.S. for several years now. So we hope for listeners that this podcast has helped clear things up for you. Join us next time for a look at tapering patients off opiates when you have to do that. Drs. Hauptman and Kaplan will tell us when and exactly how to do it. I'm Dawn Rae Downton. See you then.
Thank you for listening. If you like this episode and want to hear more, please visit www.MDBriefCase.com and subscribe to the Get Brief podcast channel. Tune in next time for another exciting episode.